Hi everyone, I'm Dr. Neil Banham. I'm the Director of the Hyperbaric Medicine Unit at Fiona Stanley Hospital, where we are recording this video for the Spums short course in diving medicine, which is primarily aimed at GPs and sponsored generously by the Australasian Diving Safety Foundation. Thank you, John Lipman. A little bit about our hyperbaric facility here. There's a photo of our hospital. It's a quaternary hospital with pretty much all services and the only hyperbaric facility in Western Australia. This is our triple lock chamber, which is a Fink 688 capable, mixed gas capable chamber. It's got an entry lock with a bathroom. The control panel is all computer controlled, as you can see here. We also have two Seacrest monoplace chambers for which we do treat divers in. We're one of the only units in Australia, if not the only one, that will do table sixes in these chambers, and we've done some 400 of those without incident so far, and we also use it for follow-up treatment tables for our divers, usually with a table 5. So my talk today is going to be about immersion pulmonary edema, and I was going to start off with a case which is one I saw here a year or so ago, and it's quite important that you take note of the specific features of this case. So it's a 54-year-old female diver who had done several hundred dives previously without any problem, and she was diving on the HMAS Swan wreck, which is an ex-Navy ship that had been scuttled in Dunsborough, which is some 300 kilometres south of Perth, which is a maximum depth of 32 metres to the bottom, and the superstructure at the top is about 16 metres. And our diver noticed that she became very short of breath some 10 minutes into the dive. So sensibly, she aborted the dive and came to the surface, at which time she was noticed to be cyanosed and coughing up pink frothy sputum. Her relevant past history that she was a hypertensive treated on a beta blocker, otherwise well, and she was on a charter boat who had 100% oxygen on board, so they sat her up, gave her oxygen, and she improved. She was taken to the local emergency department, where she was noted to have clinical signs of acute pulmonary edema. Her ECG showed some lateral ST segment changes, and her troponin was mildly elevated, suggestive of cardiac strain. And her chest X-ray was consistent with immersion pulmonary edema. This is her chest X-ray here, de-identified, and it shows fluffy opacities more on the right than the left, and some curly B lines. And so after all this had resolved, she came to see me, wanting to know if she can go diving again. All the information that I gave her and that we'll talk about today is based on a Spums position statement which was jointly made with the United Kingdom Diving Medical Committee. So what is immersion pulmonary edema? So it's known by several things depending on where you live. We call it IPO, the Americans call it IPE, swimmers immersion pulmonary edema, scuba diving pulmonary edema, are all things that it is called, but it's really all of the same thing, which is onset of pulmonary edema while immersed. And it occurs with divers, which what we're focused on here, but snorkelers, there's been many cases recorded in the Barrier Reef and also in Hawaii, which I'll talk a bit more about later. And surface swimming, particularly in long distance type swimming. So there's a big race in Sweden where they have about 11,000 competitors every year, where they have quite a lot of cases of this. And also we have a local swim here from Cottesloe to Rottnest, some 19 kilometres, where we have had quite a lot of cases of immersion pulmonary edema that we have assessed with ultrasound at the finish line. And also quite well described in combat swimmers. It was actually first only described in 1981 by Peter Wilmshurst, who was one of the co-authors of the Joint Position Statement. Peter was a keen diver, and he'd go out on his dive club boat on the weekend, and he noticed that several of the divers were coming in from the dive quite early with features of pulmonary edema. And some of these divers, mostly women, had this several times. So he did further investigation on this and published what he found in the British Heart Journal in 1981. And since that time, it's actually been recognised to be quite common, cited as occurring in up to 1% of divers, and is probably the cause of death of a lot of cases which had been erroneously ascribed just to drowning, but it may well have been that immersion pulmonary edema with subsequent drowning was the real cause in a lot of these cases. The physiology of it is as for other causes of pulmonary edema, so it's when the pulmonary capillary pressure becomes greater than the oncotic pressure, which is generated by the plasma proteins, primarily albumin. So when you're immersed in water, you get centralisation of your blood volume, probably 700 mils or more goes from your limbs, mainly your legs, to the central circulation. And as well as that, there's vasoconstriction, which varies with the degree of cold and also thermal protection. And both increased preload and increased afterload from this results in increased atrial pressure and increased pulmonary capillary pressure. And that can be exacerbated by other things as well as by cold water, by excess prehydration, so drinking too much fluid before you go diving, and also with very strenuous dives, and perhaps also by a tight wetsuit and maybe even wearing a BCD that's too small. Aspiration of seawater from a leaky regulator may cause problems with the alveolar and may be predisposing as well. And also if there's excess negative intrathoracic pressure from various causes that might suck capillary fluid into the alveoli. Some of the causes of this are faulty equipment, such as a faulty regulator where you might need to breathe in too hard in order to get a breath, rebreathers, particularly back-mounted rebreathers, and perhaps with full face masks. A syndrome of rope or rapid onset pulmonary edema is well described in snorkelers, mainly those using full face masks in Hawaii. And the reason that probably occurs is that some of those valves stick and causes increased resistance to flow. And there's been quite a few deaths in Hawaii as a result of rapid onset pulmonary edema. The characteristics of IPO, well, let's just go back to the case that I described a little earlier. So it's idiosyncratic, so it doesn't happen every time you go diving. And this case that I presented had done several hundred dives before that, so that fits in. Middle-aged females, she was 54, that's her. Onset early in the dive, so it was within 10 minutes of beginning the dive, wasn't too deep, so it wasn't decompression sickness. Cold water diving, the water temperature there, I would call it cold. It's 19 or 20 degrees, but it's certainly not tropical diving, but it's certainly not Arctic or European cold water diving. And she presented with dyspnea, cough and pink frothy sputum, as is typical. She didn't have any chest pain. She was hypoxic with cyanosis, and she did have pre-existing hypertension. And because it's recurrent, she may get it again. It was her first episode, but that's something that we really needed to talk to her about. If you're diving with a buddy, there may be some indications that they're developing immersion pulmonary edema, so they may cough, they may be using their gas up faster than normal, so making lots of small bubbles than you are. They may believe that their equipment is faulty or they're out of gas, even though the gauge is showing that they're not, so they may request some air from you or use up their backup supply, and they may become agitated panic and need to get to the surface ASAP, and they may make a rapid ascent. So the physiology of dying from immersion pulmonary edema in most cases probably is from hypoxemia, causing loss of consciousness. So if you're at 10 meters water depth and you're already hypoxic, if you come to the surface, your arterial PO2 will further fall with the reduction in ambient pressure, and you'll get shallow water blackout, much as freedivers do who hyperventilate and become hypoxic. And once you black out underwater, unless you're rescued, you will drown. Investigation of IPO, chest imaging is really important, either a chest X-ray and or CT scan and or point of care ultrasound. Echocardiography may show Takotsubo, which I'll touch on a bit later, and also blood tests. So troponin will indicate cardiac damage from this event. BMP is quite useful if the diver has been treated with first aid oxygen, has been set up, it's only been mild, and by the time they come to the hospital, all their features may have resolved, but a beta natriuretic peptide will likely be elevated with pulmonary edema, and that will be good evidence that, in fact, the episode they had was APO, so IPO rather than just aspiration. So Takotsubo, which I mentioned before, or broken heart syndrome, typically occurs in middle-aged women, the same age group as what we deal with in IPO. And Takotsubo's the name for a Japanese octopus trap. It's not a person, it's the name of an octopus pot, which looks the same as what the echocardiogram image looks like when the left ventricular apex balloons during the cardiac cycle. So Takotsubo may be found in some cases of immersion pulmonary edema as a complication of the syndrome or an associated finding. Treatment, often just removing them from the water and setting them up, in mild cases, they'll resolve quite quickly. If they've got a tight wetsuit, take that off. Give them 100% oxygen or high flow oxygen that's close to 100% as you're able. And CPAP or BiPAP, so positive pressure ventilation. In the critical care setting, maybe vasodilators. And diuretics probably don't have a huge place in that these divers are not fluid overloaded unless they've significantly prehydrated prior to their dive. So prevention of recurrence of immersion pulmonary edema is, if someone's had it before, is the best advice is probably to stop diving, and we'll talk about that more a little later. Perhaps the diver should be warned that they can also get it with surface swimming. There have been cases recorded of also divers who had previously had immersion pulmonary edema having spontaneous episodes of pulmonary edema without immersion, but that's quite rare. Avoid some of the precipitants, so a tight wetsuit, don't excess prehydrate before you dive, have well-serviced equipment. If you're a rebreather diver, and I've seen a couple of those with this syndrome who have developed it only when using a rear-mounted rebreather, and they've subsequently gone back to open circuit, and then a front-mounted rebreather, counter lung, and not had any problem. Avoid cold water diving, which is what I try and do. Abort the dive immediately if you do have symptoms, and ideally you should have surface oxygen available, and your buddy should be well aware that you have had this before and be agreeable to diving with you. And to allow a direct ascent to the surface, you should avoid any diving where you have a decompression obligation. If you do have an episode of IPO, it's very important to get a full cardiovascular workup to make sure that you don't have any occult cardiac disease that may have precipitated or made you more prone to having IPO. So that's recommended. Some have advised sildenafil or Viagra or other similar medications as a prophylaxis, and Peter Wilmshurst has advised his colleague divers or dive club divers to take nifedipine 5 milligrams pre-dive. I've not known of anyone that has used that, but it certainly appears to help according to personal communication with Peter. The full joint position statement, which you can find freely available alongside other position statements, is on the Spums website. But the most important statement in this position statement is that if you have had an episode of immersion pulmonary edema, that you shouldn't scuba dive or compressed gas dive. The other statement is to be fully worked up for underlying cause, including cardiac disease and equipment issues. And if known to have hypertension, you should have ongoing, lifelong regular blood pressure checks to detect any hypertension at an early stage, and if it occurs, look for the cause and perhaps treat it. Such conditions as renal artery stenosis. So lifelong blood pressure monitoring is recommended. I advise divers who have had episodes of this that they probably shouldn't dive again. They should consider it very strongly, and if that they are considering diving, they need to take the precautions that I have said, and I offer them also a full cardiovascular workup, because some of these divers, most of them have been women, most of them have been in their 50s, and they're the sort of age group that may also have occult cardiovascular disease that can be detected and successfully managed. So I hope that you found this talk interesting and useful, and a reminder that if you need more information, or you do have a problem, or you do have a patient that you want advice for, or for someone to see them to give them advice and assess them, is that there is a hyperbaric unit in each of the capital cities in the states of Australia, and also in Auckland, New Zealand, and Christchurch, New Zealand. So there are plenty of people with expertise on this subject out there, and also to refer to the joint position statement of Spums and UK DMC. So thank you.